So this morning we're going to talk about fishing. So it's probably not very common that this fisherman, who is made of rocks, catches a fish. But it is probably also not very common that we see lung biopsies for interstitial diseases. These are not commonly pursued in our hospital, and I don't think in your hospital either. So it's a nice opportunity to review the main considerations, but it may not be something you will put into practice tomorrow, but we'll hopefully make it worthwhile and interesting to discuss. Chronic lung disease has many different varieties. The more problematic one are these interstitial pneumonias that we don't know what the cause is. So this is sometimes called IIP, and it has all of these initials: UIP, NSIP, COP, RBILD, DIP, LIP, lots of different acronyms. And we'll go through most of these fairly carefully to help you understand both the acronym but also the differences between these disorders. There are also settings where people have other diseases that influence their lungs. Collagen vascular disease, like Sjogren's syndrome, or rheumatoid arthritis, or something like that. And then there are various eosinophilic diseases, sort of like the eosinophilic diseases in the colon and bowel. These also can be confusing and cause symptoms, but not have a known process. Drug reactions are quite common in the lung, but we don't biopsy the lungs for drug reactions, so we don't see them very much. And then granulomatous diseases, we'll talk about these, and then a few of these other lesions that don't really fit into a good category. As we talk about these, again, I want you to think about the patterns that we talked about of lung injury: diffuse alveolar filling, chronic infiltrates, nodules, fibrosis, nearly normal lung. The things that we will use to differentiate these are what part of the lung is affected: alveolus, bronchus, interstitium, et cetera, whether it's uniform and diffuse or whether it's localized, and the kind of cells that are involved in the process. We'll also look to some degree at the stage, whether it's a progressing or whether it's chronic. There are several problems that we have to deal with, and that is that most of these interstitial lung diseases are of unknown cause. We don't understand fully the pathogenesis. And I'll tell you a little story. My mother-in-law, my wife's mother, developed a severe respiratory problem with shortness of breath and so forth that ultimately led to her having a lung biopsy, a wedge biopsy. And when they looked at it, it looked like it could be Wegener's granulomatosis or something like that, and so she was treated on that basis. But as she talked about her history, she said, "I remember very distinctly when it started because they were burning some bushes outside the house, and in those bushes were a particular variety of plant that creates itching and burning, called poison ivy. And she said, I breathed some of this smoke from the poison ivy. Well, as far as the biopsy was concerned, we didn't know the cause. It was idiopathic. But the history then told us that it was probably this toxic exposure to the allergen or the irritant in the smoke. So that's one of the problems that we face. And then, of course, some of these diseases, particularly the fibrosing ones, can produce significant mortality, almost like cancer. 40, 50, 60% of these patients will progressively get worse and die. So it is an important area if your patient has this disease. The classification of the majority of these interstitial lung diseases goes back to Drs. Lebo and Carrington, who had the opportunity of looking at a large number of cases of prior biopsies, both autopsies and biopsies, of patients with these kinds of lung diseases and having their outcomes known. Many years later, when I was first starting residency, I interviewed with Dr. Carrington, a very interesting fellow, and I didn't really appreciate how famous he was at the time, but they had done this great work in classifying lung diseases. Now, our understanding of these diseases has changed a little bit, particularly some of the fine-tuning of desquamative interstitial pneumonia or some of the bronchiolitis-related pneumonias. And also the classification on lymphoid pneumonias has changed because we've seen that some of these have lymphomas in them, or they may have other processes in them that we can separate out. So the classification that's used now is a little bit different. It still has several of these entities: usual interstitial pneumonia, desquamative interstitial pneumonia. But now we have respiratory bronchiolitis interstitial lung disease, or respiratory bronchiolitis. And we have what's called an acute interstitial pneumonia that's also been added, and this nonspecific category, which is a little bit different. These are pathologic terms up here. This is what we might sign on a report. But it's important to understand that a radiologist has also looked at these, and they have clinical features that also correlate. So usual interstitial pneumonia is intended to imply a particular progress and a particular outcome. And it correlates with the radiologic features of pulmonary fibrosis or cryptogenic fibrosing alveolitis, a fibrosing disease that produces honeycomb change and so forth. And likewise, each of these other disorders has particular clinical patterns that the radiologists will describe. Sometimes it's the same, like DIP here, or cryptogenic organizing pneumonia, and sometimes it's a little bit different terminology. So recognizing that it's very important to correlate what we see with what the radiologist has seen and the clinical course to that point. So with that, we'll start with the most common of these, which is usual interstitial pneumonia, or UIP. And when we use that term, it's like calling something a particular type of cancer. It implies a treatment response, a clinical course, and prognosis. So we should make sure that we're not using this just as a fibrosing interstitial disease, but that it's actually going to have this progressive, aggressive pulmonary fibrosis. These are usually older adults, and they have had dyspnea and cough. Clinically, they will have some crackles, particularly in the bases of the lung. They may have clubbing of their digits, indicative of lung disease, and the radiography will show these reticular opacities. So here's what those look like on a CT scan. Here at the base of the lung, you see a little bit of interstitial changes. Whoops. Interstitial changes here that correspond to this reticular pattern of disease. What we see on the microscopic exam is characterized as what's called a mixed or heterogeneous pattern, patchy, different areas of the lung, and at different stages of fibrosis. So here is what's thought to be the earliest lesion of fibrosis, a very small focus of loose fibromyxoid tissue. So this is a difficult disease to make a diagnosis of on a biopsy, a small biopsy, an endobronchial biopsy. Usually it requires a wedge biopsy to make this diagnosis. We may also see entrapment of smooth muscle or the presence of smooth muscle in the subpleural areas or in the interstitium. And there will be a microscopic change of honeycombing fibrosis, thickening and firming up and rounding up of the alveolar spaces. So here's a low-power image to show you areas of involvement, areas of sparing, and here we see there's some smooth muscle in there going on as well. Here's the smooth muscle metaplasia, can be quite prominent, but may be very, very patchy. And occasionally, with UIP, you can see some alveolar filling type of changes. So you don't let that distract you from looking for the fibrosis, the little active foci of loose fibrosis, and the inflammatory process, maybe smooth muscle. This is the lesion, these fibrotic foci, what they look like. And you see there's a few eosinophils, loose fibroblasts, myxoid tissue, and maybe an overlying relatively normal alveolar lining cell. It's thought that architecturally this is like a line, or these are continuous throughout the lung. But architecturally, if we were to be able to follow them along, they would be throughout the alveolus as a continuous area like this. But when we section them, we just see a small focus. Some people will also count these in a biopsy or in an area and use that as a measure of activity and how likely the person may be to respond to steroid treatment or so forth. This is the differential diagnosis list. I'm not going to talk about all of these right now. This is a long list of things to also be considered. And so the bottom line here is I think that almost every lung biopsy for interstitial lung disease, you have to think about this as a possibility because it can overlap with so many other things that can look similar. Some will be even more nodular, like Langerhans cell. Histiocytosis is usually a more nodular area, but can have a fibrosing pattern. And some of the other inflammatory diseases, collagen vascular disease, the other interstitial pneumonias, can also be considered in this. As we go through each of these diseases, though, I think you'll begin to see how this differentiates from the others. So here's an example of how one person might put together their report. Given that it's such a broad differential, our level of certainty may not be absolute. So in this report, he said this is a fibrosing interstitial pneumonia with a little bit of honeycomb change and fibrosis, some smooth muscle metaplasia, and the level of fibroblastic activity, focus activity is low, medium, high, so according to our count. Then, this is the caveat, these changes are characteristic of those patients, those seen in patients with idiopathic pulmonary fibrosis, UIP, and correlation is required for a definitive diagnosis. So we've put it where we think it probably is UIP, but we say it needs to fit with the clinical picture, radiologic picture, etc., before you can firmly make that diagnosis. So these are the criteria that should be met as you make this. It should be patchy, not diffuse. So this is going to be in the fibrosing or chronic cellular infiltrates patterns in the lung. It's going to have some loss of architecture with fibrosis and remodeling. And there will be peripheral zones of scarring with honeycomb change, and should be smooth muscle to go along with that. There may be some lobular sort of accentuation. It may start to look like it's pulling the pleura down in, and it sort of will look like the scarred pleura of an area that will be seen at an end stage. And usually the center of the lobule will be slightly spared. So this will be what will make it look like honeycombing. And then you need to find at least some fibroblastic foci at the juncture between fibrosis and normal lung. So this is the active site of the fibrosis and scarring. Okay, the next disorder we'll talk about is nonspecific interstitial pneumonia. This is also usually younger patients, sometimes children, who have a more gradual onset of shortness of breath, maybe some fatigue or anemia or weight loss, failure to thrive. This is usually in the lower lobes, and it, again, can have sort of reticular radiographic infiltrates. Lung volumes may be reported as being lower. If we don't see fibrosis and scarring with this disease, it can have a very good outcome. So this is more likely to be maybe related to some unknown infection or some gradual mycoplasma or something of that sort, but it can have a very good outcome and spontaneous outcome. In contrast to UIP, which has areas of maturing fibrosis and areas of new fibrosis and maybe some alveolitis, this is all the same. It all looks at the same stage. The degree of inflammation is uniform. And it tends to be the alveolar walls, not the interstitium or the paraseptal areas. There's no honeycombing and minimal fibrosis. So here we see, this is a more diffuse process, right? This is the chronic cellular infiltrates pattern. Remember that? And although it's got some lymphocytes in it here, we really don't see much in the way of real fibrosis here. There is some thickening of some of these septal areas so that we might be suggestive or worried about fibrosis, but it's not that mature fibrosis and dense scarring, and there's no smooth muscle like we would see in UIP. Here's another picture. Again, you see it's diffuse, it's everywhere. That's not the pattern of UIP, which is patchy. And here, higher magnification, you see there's preservation of the alveolar septi and some chronic infiltrates there. Now, it's called nonspecific because we don't have a better name, but because it could be a variety of factors leading up to it. Here's again another picture, just sort of to help you cement this pattern in your mind. That's why I put so many pictures in, is to help to reinforce the pattern. A diffuse chronic cellular infiltrate pattern without fibrosis, smooth muscle metaplasia. Occasionally, you can find little areas like this that are small foci of organizing pneumonia. That's okay. But they shouldn't be extensive. It shouldn't be all over the biopsy. That would be a different pattern, more likely an organizing pneumonia type pattern. But small foci are okay. Here's the differential diagnosis for this organizing pneumonia pattern. Oops. I may have got this slide out of, I got this slide out of order. So we'll come back to this here in just a second. Because we want to talk about cryptogenic organizing pneumonia, or COP. This is, again, a disorder that we don't know what causes it. It may be like, tropical sprue. We don't know what causes it, but we know how to treat it. So it responds to steroids, and usually these patients may develop complete resolution. They have cough and a little nonspecific inflammatory process, and here you see it with organization in the areas, and it's fairly widespread. This is not just rare foci. There's some acute inflammation associated with it, as well as some chronic inflammation. Here's a little higher magnification. You see this branching, organized area of alveolar space filling with loose fibrous tissue. It's in the alveolus, not in the interstitium, not in between the capillary. So it's inside the alveolus. Now, occasionally, this process can lead to actual ossification in the alveolus. And that's what I've shown you here in this image. These are actual little bone spicules that follow along the pattern of the alveolus. When you see this, you kind of scratch your head and go, what is this? I have only seen this a few times, usually at autopsy, but it's because it has a precursor in the cryptogenic organizing pneumonia. And this is called the racemose alveolar ossification. So racemose means branching and curved-like. So let's go back and look at the differential diagnosis for this disorder. As you would expect, infections also can produce organizing pneumonia and may be included in this pattern. A diffuse alveolar damage, later stage, can produce organization as well. And some drugs may also produce diffuse alveolar damage or organizing disorders. So those are the most important ones. Hypersensitivity pneumonitis can be seen with this pattern, but the organization is usually not so extensive, and there usually would be things like small giant cells or granulomas, and a lot more eosinophils to be associated with that. And then chronic eosinophilic pneumonia, which we'll talk about later. So anytime you see this organizing pneumonia pattern, this is the differential diagnosis, and in this group would be the cryptogenic organizing pneumonia at the end of it. The next most common disorder that we can see here is respiratory bronchiolitis or respiratory bronchiolitis associated interstitial lung disease. Now, as we talk about this, I think this is a spectrum type of disorder where we have respiratory bronchiolitis, then respiratory bronchiolitis, interstitial lung disease, and then finally, at the other end of the spectrum is desquamative interstitial pneumonitis. So this can be a little bit more difficult to distinguish between things. And Dr. Holm, this is a smoking-related disorder, in case you need another reason to quit. I tease him about this. It usually is fairly young age of onset, mid-30s and so forth, but it's very much dose dependent. So as you see here, it sort of averages about 30 pack years of smoking will lead into this type of disorder. Not everyone who has 30 pack years gets this, but almost everyone who has that many pack years will have respiratory bronchiolitis. So that earlier stage in the spectrum can be there. And there may be some thickening of the airspace and some ground glass opacities, which sort of correspond to the desquamation type process. Relatively mild inflammation. You may get bronchiolar epithelium extending out along the airways into the alveolar spaces. And then you'll see these pigmented macrophages in the alveolar ducts and around the alveoli. So let's see what that looks like. Here it is. So here's the respiratory epithelium extending out into the air spaces. A little bit of fibrosis may be associated with that. And then these pigmented macrophages in the lumen, and maybe a few of the surrounding alveoli will have them as well. Now obviously other particulate disorders like living in an urban environment and so forth can also produce some of these changes in terms of pigmented macrophages. Here's another example. You see a lot of these pigmented macrophages, a little bit of peribronchiolar fibrosis, and the alveoli also slightly involved. The far end of the spectrum, desquamative interstitial pneumonia, also is a smoking-related disease and tends to be slightly older adults than respiratory bronchiolitis or respiratory bronchiolitis interstitial lung disease. These patients also will have gradual onset cough, and they may have clubbing or other changes of lung diffusion capacity. Sometimes it's clear on the x-ray, other times there's little opacities that can be seen related to the desquamative changes. So what pattern is this? There's a lot of macrophages, and they are where? Inside what space? In the alveolus. So this is the alveolar filling pattern that we talked about. And this is the main thing on the differential for that, but other things, pneumonias and so forth, could also have this low power pattern. This is just one of the differential considerations. So here at higher magnification, you see that the majority of this is these alveolar macrophages that fill the air spaces, and there's some associated thickening of the alveolar septi with some inflammatory cells in that space. Not really any true fibrosis, but just some increased tissue there. Sometimes this can actually become almost solid. Hard to distinguish here where the alveolar linings areas are because it's so diffuse in this process. The differential for this process, of course, is any of the alveolar filling disorders, but particularly eosinophilic lung disease. Sometimes chronic passive congestion can produce alveolar pigmented macrophages, pulmonary hemorrhage, giant cell interstitial pneumonia, and Langerhans cell histiocytosis, which we will talk about later in this process.